Denis is a colleague from Madrid. He works in a hospital. In this hospital, Dr. Octubre is the hospital where we developed our NGS study we presented last year. So there are a third class hospital there with very top doctors there. Denis is going to be a top doctor soon. He's becoming to get there, and I think that probably the skill they have treating ITP there. They have Carlos. They have quite a specialized ITP leader in Spain working there, and I think that they have enough knowledge to let us learn a lot of ITP.
Okay, thank you, Tomás, first of all, for inviting me to this forum full of leader opinion in treating patients with ITP. And you propose me to answer that question, if there is still play a role in treating patients with splenectomy in ITP. So let's see what I found. No conflict of interest for this talk. And through all the presentation, I will walk you through different topics with a briefly historical background, with a rationale for splenectomy, its risk and long-term complication, some evidence bringing from past to recent studies, some predictive factors for response and relapses, some of comparison studies with the other second-line treatments or medical treatments, and a briefly of summary guideline recommendation, and finally conclusions. So the briefly historic evolution, splenectomy came to the treated of patients of ATP in the past as one of the most effective treatment for patients with refractory or relapses after corticosteroid. It continued appearing the problem of overwhelming postoperative infection with this treatment, and they get better outcomes with the laparoscopy era. And then after what is the position when the medical therapy like rituximab or TPO appears, and now maybe we are more predictive model or registered data, what is the candidate for the treatment in these scenarios. So splenectomy play a role? Well, it could be said that could be one of the most effective initial treatment, but they induce long-lasting remission. One thing it's say that this patient get free of treatment, but it's difficult to predict which patient will have a response or relapse, and consideration of splenectomy normally is limited to some kind of patients nowadays. So the thing is that splenectomy is less and less frequently used as a standard therapy today. The current, there are ongoing studies that they try to assess its effectiveness in different kind of scenarios, and could be essential in selected cases when other treatments fail. So I will start with some of the splenectomy risks. That most of them, there was the post-splenectomy, one of the risks that they have with this treatment is the splenectomy infection with vagination, the risk decrease, but overall they have an increased ratio of infection. Depending on the report that you revise, the group of Italian with more than 400 patients that we will see later, they find no fatal infection, but with another publication in 2013, they found with a median follow-up of 200 patients, 2 fatal infections, but they were old people. The thromboembolic events in the early postoperatory time, they have an increased risk of portal venous splenectombosis, but some of them could be asymptomatic. And the risk of venous thromboembolism is in risk. Let's see the postoperatory risk in the other slide, and the perioperative morbidity and mortality, depending on the review, it goes from 9% for laparoscopy to more than 13% in the open splenectomy group. Laparoscopy have less mortality than the other. So here I have this slide from this educational in 2018, where they review more than some of the articles with more than 50 patients with a median follow-up of 3 months. and still the risk of venous thromboembolic events maintained with the time, even a long time, years. Some of the variants that they describe that they could be more severe disease in the splenectomy group than the others. And for arterial thromboembolic event, there is no clear that the splenectomy could be responsible of high risk in this population. Normal data come from other splenectomy, like hereditary rectal disorder or other populations that get a splenectomy. So I will review first like more past evidence, but in the era of 2000, and then the things that I found in the last year. Here is a review of different kind of articles that are mentioned in different reviews. And in Blood 2004, this with a systematic review of more than 16 patients that includes adults and children, they describe a splenectomy after glucocorticoid, but no specific time, with an overall response rate, the whole population around more than 80%, with complete response around 60%. The relapse is around 50% with a median follow-up or more than 3 years. The main complication, as we saw before, is laparotomy. It's higher than for laparoscopic group. The Vianelli group, the Italian group, with more than 400 patients with splenectomy performed at younger age, around 36 years, with a median time of 14 months. Again, complete response more than 80%, but with no respondents around 14%, with relapses more around 23% of this population during the follow-up of 14 months, with a 3-year relapsing rate around 75%. Again, peritoneal infection was a problem, and during the follow-up, they find 2% of thrombosis, 3 fatal and 3 fatal deaths due to hemorrhage. What it's tried to investigate here is if the laparoscopic splenectomy had different outcome in the short-term and long-term failure. With more than 1,000 patients in this observational study during a follow-up for more than 12 months and more than 15 patients in these groups, with a time to splenectomy around 26 months, they have in the short term no responses around 80%, with a long-term relapse rate around 28% during the follow-up. But if you take in that figure, the failure rate decreased with the time if you put all the reviews in line. They said that maybe the shorter duration during the follow-up did describe more relapse rates, and some of them could be insignificant. But they also tell us that the conversion to laparoscopy to open laparotomy is around 55% of the patient. And in 2013, they tried to find efficacy and safety in people more than 65 years. And here is another retrospective analysis with more than 200 ITP patients that compare elderly patients with younger patients. Overall response, it's around more than 80% again, with better outcomes in the younger population, that it's around 90% versus the 79% in the earliest. No response around 11%, but relapses again more for all than for young people, around 42% for all, 28% for young people. Early complication, more in the elderly group with more bleedings, with more long hospitalization. They don't find differences between thromboembolic or infection rate between both groups, but mortality was higher again in the older groups than the younger ones. Here, like a brief review of all that article, the response rate is more than 80% in all of them. The one is like the complete response, but it's around 8%. And what happened with no response or relapse, depending on the article you revise, but it's more or less from 15 to 30% in the relapse rate, with around 10 to 15% with no responders. And what kind of predictive factor? Of course, they try to find what kind of people could optimize with this treatment. Most of the articles, they publish that the younger diagnosis and less time, less prior lines have better outcomes. Depends on the analysis that you revise. The univariate analysis, for example, in the Vianelli Italian group, younger diagnosis and splenectomy is a predictive factor, or the number of former therapies or higher peak splenectomy platelet count has better outcomes than the others. Again, the other one, average mean direction of TPA of splenectomy is one of the favor factors to respond. And what in the other, again, younger patient at the splenectomy has higher response rates than the older ones. Less lines, and they also reviewed that laparoscopic complications are in favor than laparotomy ones. And what have today? Because there is an old treatment, but there are still publications, some kind of reviews and some kind of information. The first I found that the EHA in 2024, last year, from the Data UK ITP register, they found 400 patients who received a splenectomy, and one tried to identify where to locate this treatment. So they make two cohorts, less than 2 lines prior to a splenectomy or more than 3 lines. And the median time to treat that patient after a splenectomy in the cohort 1 was calculated at around 20 months versus the time to first treatment post-splenectomy in cohort 2 around 3 months. So they position like an early treatment in second-line therapy. Maybe you have to respond it, but in refractory patients, the rate is poor. But there is also more articles with different sample sizes. This is published in 2024. Is another retrospective cohort study from the New York Center between 2010 2021 in an era with more therapies that we are treating now patients, with a median time to splenectomy of 1 year and a preoperative therapies received with a median unique line of 2. And here again, the response rate, if you focus on platelet count at 30 days, most of the patients get response, more than 80%. But during the follow-up, platelets get still in complete remission, 85 patients, but they are only focused on platelets. And there are no response in 2%. But what happened with the treatment of that patient? In the last follow-up, they found that they didn't need no further therapy in 60%, but 12% received any kind of treatment during the follow-up, but in the last year was off of therapy. Under 22% they are on another treatments, with a median time of follow-up of almost 4 years. Predictors here, they find significant difference about the spleen size, less line treatment, and younger rates. They find no difference for other kind of different history of antiphospholipid, SAB, or other comorbid conditions. And what happened about complications? Again, thromboembolic events are one of the main problems. They find two mortality during the first 30 days, and they perform most of them in laparoscopy way. And here there is a recent public article with another review with more than 200 patients, but they take patients from 19th to today, with a median follow-up of 93 months, and the median time to a splenectomy around 2 years. But here the preoperative therapies that the patient received, only one before in 160 versus more than one in 57 patients. Again, they found a response rate at around 80%, and no difference between a splenectomy or laparoscopic group. What happened with the use of splenectomy during time? Of course, they marked 2012 as the point that they performed less splenectomy treatments because of the appearance of the new treatments. And meantime to relapse, most of the patients relapsed during the first year, and they find in the univariate analysis of predictor risk for relapse more patients with hepatitis, steatosis, diabetes, or obesity. When they perform some variety analysis, they only found that female and less than 40 is a predictor factor for less relapse. And complication, they have a high morbidity, but they explain that most of the treatment are by open splenectomy, and they have less experience in laparoscopy splenectomy. As you can see, only 15% went for laparoscopy, with 26% of morbidity. Yes, there is a procedure that you need experience to be practiced and to get less morbidity that we saw before in the other series. And this could be an interesting study from an Italian multi-center group that we tried to find or tried to prove some cohort of patients just to a discover set and a validation set just to get what kind of predictive factor we can analyze to poor response. And they found that the HAC diagnosis, autoimmune comorbidities, and hypersplenectomy corticosteroid use were associated with poor score, as you see in the left of the slide. This is the experimental, the discovery population. And they tried to combine with a histological insight that reduced the follicular herpes or hypoplasia in the marginal zone. If you combine them, you could have better outcomes or better predictive factors. So when they perform the survival analysis, the result confirmed that the patients that are located in the high-risk group have less relapse-free survival, around 22 years, it's around 40%, versus the low-risk group that they are around 90%. So this model could predict some of the patients, but they need a validation external cohort. And if you face splenectomy with other treatments, I only bring here some briefly reviews of one of the article that I could find that compare both treatments at the same time. Here, in a group of Turkeys, they perform splenectomy versus thrombopack, and they don't find significant difference between the duration during the follow-up during 2 years. Adverse event, again, was more thromboembolic events in the splenectomy group than the TPO, would have the typical adverse event that we normally see in that kind of patient. And they also suggest that when they also treat patients that relapse in the third line with thrombopack, and they also recover or rescue that patient with second line treatments. So, and what happened with rituximab? I can't bring here more studies because it's the other treatment that could be patient-free of treatments. So starting from today, from less old article in the first one, retrospective comparative study from patients with ITP, they found more complete remission in the splenectomy group than for rituximab, with a sustained complete response ratio around 66% for splenectomy versus rituximab. In the key finding on relapse, the 5 years complete remission estimated was better for splenectomy than rituximab. And they found that in the logistic regression, the unique predictive factor of long-term remission was splenectomy. Problems, again, thromboembolic events in the population with a mild effects on rituximab group. In another retrospective study, they tried to find if rituximab first or after could have any kind of difference of this patient. Again, when they focus all in response about the splenectomy versus rituximab in the first figure, they found more response rates for splenectomy than for rituximab. Even in the freedom from relapse was better outcome in the splenectomy group. When they combine, if it's first or after, they don't find any difference, but when they follow the patient that gets rituximab in third line, they get more response ratios, more freedom from relapse when you use in second line, so they can rescue patients from splenectomy. In 2018, another quasi-experimental cohort of patients, they're trying to find if the patient are aligned to splenectomy or rituximab, if there is any kind of difference. There are only 19 patients who underwent who go to rituximab and 11 to splenectomy. They couldn't find any kind of difference that at the first moment they perform splenectomy, they get more platelets count than during the follow-up, that they are similar in both cohorts. And the last one tried to adjust the comparison of mortality and morbidity versus splenectomy versus rituximab. So the probability of response maintains was 4 times better, or have a 4 times probability for splenectomy than for rituximab at 12 months of follow-up. The problem is that in the splenectomy group has more morbidity, bleeding, infection, and hospitalization than the other group. And the French group tried to answer a little bit that question, if there is, in the era of thrombopoietin receptor agonists, if there is new insight or new evaluation from this old treatment. And they review patients from 2011 to 2020 with more than 100 patients, adults with primary ITP. Median age 50 with a median follow-up or almost 40 months. And again, the initial response located around 78% with 12% of relapse, but with a sustained overall response rate around 64%. When they analyze after sustained remission after only one treatment, or TPO or rituximab, they decreased until 60%, but when they combine both treatments, they have received patients with TPO and rituximab and post-splenectomy, the sustained response ratio decreased until 46%. But there is still a way to rescue that patient that relapsed, but respond to TPO after splenectomy, 61%. And what about the complication after splenectomy? Again, they found in the first 3 months some of 32 patients with thrombotic events, but most of them were portal vein asymptomatic thrombosis. Another additional thrombotic event in 14 patients, and 3 described 10 patients with severe infection that require hospitalization, and 3 days splenectomy related. What say the guidelines? Well, at birth review, most of them located more than 12 months. The newest in 2018, more than 12 or 24 months. They try to emphasize just to locate it, depending on what you say, but most of them is after TPO. Clearance. And brave historical group in this review in 2018 with lots of series of cases, they report that splenectomy with the splenectomy pattern was observed in 90%, and for splenic, from the other type of patterns, hepatic diffuse or mix, around 40%. But they describe a limitation of techniques, response criteria, and follow-up period. But today I found two recent articles, one of the group of Mendoza in Hospital La Paz, that they studied the platelet kinetics in a unique center of 50 patients. When they compare the probability of response, again around 80%, but the relapse-free survival between the one who has the splenectomy part, the splenic pattern, they have less incident of relapse of this treatment with a good sensitivity and specificity, but they don't find any other kind of clinical predictors. And they postulate, because they work in the platelet deessentialization, that the non-responding patient has significantly lower level of cyalic acid than the others. And another study that tried to figure if the course of immune thrombocytopenia on the side of platelet destruction could predict some outcome of your patient. Here's a retrospective study, and they only select splenic or hepatic pattern, no mix or others. And ITP diagnosis to perform this technique was 15 months, and what they found as the distribution of the cohort is more 97% is have a splenic pattern, but when they see the type of ITP evolution, most of them are chronic in the chronic distribution. What they find in the univariate analysis is that the hepatic pattern, they have more number of relapses, more number of treatment use, they receive more rituximab or TPOs, and they have more autoimmune inflammation-associated disease with more cardiovascular disease. And the patient that performs splenectomy in the splenic pattern, because they don't perform in the other groups, they found 39 remission and 6 relapses. And just to finish with the first question of still play a role, well, I tried to make a brief review about all of the revision. That could be, say, maybe yes in chronic ITP with good response ratio initially, at least, maybe in younger patients, they impact less the comorbidities of this procedure, that you have a patient that want to be, because any kind of reason, free of medical treatment. So try to find that splenic site destruction with a laparoscopic intervention or hospital with experience. And of course, that the patient could follow the vaccination and educational program. Or no, early or persistent ITP diagnostic, of course, there is no possibility, or there is no result at all. With an overall response ratio with another medical treatment that could have similar ratios, with suitable for all ages, with less accumulative risks and possibility of switch, discontinuation or not, depending on what we have been seeing today. And you have another second-line medical treatment with lots of new drug combination or clinical trial that we are experiencing. Some of that multi-refractory ITP patients still play a role. Maybe the thing changing, so countries is common and political change, it could impact in that treatment. So it's good to have a review from time to time of different kind of views. And different of splenic pattern, elderly and surgical experience. And could say no from maybe yes or doubts. And thank you.
Thank you. I'll come to you in a minute, Rick. We have a question from Sylvain, who I think is online, wants to ask a question.
My question is regarding platelet scintigraphy. We are using it in France quite a lot in difficult to treat patients to decide whether they should undergo splenectomy or not. But yeah, the response is not 100%. Do you think it could be wise to combine with other markers, such as biomarkers or demographic data from our patient? And what is your feeling in clinical practice? Should we perform platelet scintigraphy to all our patients or not?
Well, when I reviewed to perform platelet scintigraphy for all patients, I think there is no popular in all centers. It's difficult access and difficult to interpret it. So maybe it could be half a point if you need or you are thinking about performing splenectomy to your patient. And to predictable markers, when you review lots of papers and upon from age or time to splenectomy, for one of the most repeated, but not all confirm that kind of predictive factor. I think it's more a decision making with patient that could. You have a decision making with your patient that could need to be free of treatment. Maybe that's kind of different, that kind of predictive factor to take account just to finally recommend or not splenectomy. I think so. But I don't know what the audience thinks about.
Okay, thank you. I think Rick has a question. Thanks, Sylvain. And then Waleed.
Yeah, thank you for this overview. Now, I would like to comment that I think it's of course very important to keep in mind the underlying biological mechanisms. And in this respect, I think the platelet scintigraphy, I would say, would be highly recommended. We, in fact, very recently did a study in healthy volunteers to see their sequestration patterns. And also on that level, so these did not have ITP, but they also differed. Some were splenic, some were hepatic, some were mixed. And this was actually very comparable when we did the same thing for the ITP cohort. So I think this is, if you would consider it, I think this would be highly valuable to see what's actually going on there. But I think also the downside, of course, is also the infection risk. So you don't want to. I think that's probably one of the main reasons most of us probably haven't done any splenectomies over over the years. So that's also, I think, a challenge then.
Did you say normal volunteers? Did you say normal volunteers?
Healthy volunteers, yeah.
But they're
Because
not, they're not opsonized, are they? The players?
no, but their platelets get cleared also when you transfuse them.
Is that the same as
Autologous platelet
ITP?
transfusion.
Is that the same as ITP?
No, because they don't have. Yeah, mechanistically it can be the same, but there's no pathological trigger.
Okay.
So it's clearance of autologous platelets. So this data was lacking. That's why we conducted this study to see, but it already revealed heterogeneity there. It's not like everybody has the same, and then they get the ITP and then it differs. It already differs. So, yeah.
Very comprehensive and very nice review, Dennis. A question that about the splenic embolization. I mean, many places, even in Norway, we have many hospitals that they perform it. What is the literature of the evidence of response and?
I didn't review that kind of part of the, because I didn't find so many things, and I prefer just to go through this kind of mechanism.
Thank you.
No.
I think the Indian labeling is good. We've done a lot. I mean, Adrian started it way back in the 80s. We've done many. We don't do any now because we don't do splenectomy, but we do them for other people. It's a very cheap test. It costs about £1,000 if you compare with the drugs that we use. It doesn't guarantee success with splenectomy, but it often helps the patient make a decision with the clinician. If they're undecided and it's, say, mixed or hepatic, then they say, no, I don't want it. So it's a useful test and it's pretty cheap. But the problem is you can only have it done, I think, in Paris and Bart's in London. And that must be new then. Is that new?
No, it's been there for a while.
Has it? And the Czech Republic, I think, had it as well. But it's not everywhere. So that's why we didn't put it in the guidelines. We can't recommend it because it's so few places offer this test.
Thank you.
But it's a nice talk. Thank you so much, Denise. Thank you.